This is the Owens Recovery Science Podcast, hosted by physical therapist Johnny Owens.
All right. Welcome back to another Owens Recovery Science Podcast. This is Johnny Owens. We've got an awesome podcast today because we're right on the heels of baseball winter meetings, right on the heels of this World Series where my team, the Astros, got beat, man. And we're going to have a talk with a couple of experts, and this is our World Series blood flow restriction edition. We got Jeremiah Randall, who's the head athletic trainer for the Houston Astros with us. And we have Seth Blee, who's the head physical therapist for the Washington Nationals with us as well. And so we're going to try not to fight about, this World Series stuff and who should have won, who could have won or whatever. We're going to be nice. We're all friends. But we really want to kind of get into deep dive of what an actual clinician does with a baseball team. What's their kind of pain points from injuries to recovery to everything else, and then kind of what these guys are doing with blood flow restriction, and who knows where we'll go from that. So I'm just going to do the bios here real quick. These things are freaking long, guys. So Jeremiah Randall, he's a PT, ATC. He's been with the Astros since 2015. So the freaking glory years, man. When I was really tracking the Astros back in the day, we were the bottom dwellers. So maybe it's what you're doing there, Jeremiah, but World Series in 2017. In 2017, he and his staff were chosen as the MLB Athletic Training Staff of the Year, which that's given out by his peers, PBAS, Professional Baseball Athletic Training Society, which is always cool to see recognition from your peers. And Jeremiah has been in the league for a while, so he was with the Pittsburgh Pirates for 3 seasons before that as their major league rehab coordinator, and then he was with the Los Angeles Dodgers as their minor league rehab coordinator since 2010. So dude knows him some baseball. Like so many people, he got his DPT at the University of Miami with my main man down there, Larry Cahalan. And then he is also an athlete. So in undergrad, he was a 3-year letterman in basketball, track, and received all conference honors, man. Good for you, brother. All right. And then we've got Seth. Let's see how Seth compares here, man. Seth is a good old friend of mine, and he's at Nova, which is up in the D.C. area. And he works at this amazing, freaking massive new Nova sports medicine complex with one of my favorite orthopedic surgeons in the world, Dr. Robin West. He's also director of 18 outpatient clinics up in that whole Northern Virginia area. He went to Boston College for undergrad. This dude's like Northeast the whole way. Then he went to Columbia University for his MPT. He's freaking certified in like everything that a clinician can be certified in. He also, like me and Kyle, he gets out and teaches quite a bit for different groups. And also Seth is an athlete as well. He wrestled at Boston College. You don't even have cauliflower ears, dude. Did you really wrestle? I haven't seen those.
Johnny, I will tell you, I wore my headgear every practice.
Okay. So you just got the wrestling herpes, but you didn't get the cauliflower.
Plenty of ringworm to show for it.
Yeah, that's good. And then in 2016, Seth came on with the Washington Nationals as their team physical therapist. So thanks, guys, for being on here. I know you guys are busy. We've been trying to do this, I think, since the World Series, but everyone's flying around, moving around, and it's hard to get in. But basically, kind of, we got people that are outside the United States and that listen to this, and people who might not know the way baseball kind of flows. So take me through both you guys kind of organizations of how do you manage injuries? What are the kind of injuries that maybe looking at last season that you were dealing with? What's the decision? Do you keep them close to home? When do you decide to send them down to maybe the minor leagues? And then just kind of what are other pain points keeping these guys recovered when you're flying around all over? So if you guys can take me through that scenarios, maybe Seth, go first.
Sure. Well, my situation is probably a little bit different than Jeremiah's because I'm not with the team full time. So I'm a PT, but I'm not an athletic trainer. So I'm with the team when they're in town. I get to get back in with them every time they come back in and work with our athletic training staff and our strength staff to manage things while the team's here. And then my role also is when the team goes on the road, anybody that's not traveling, that's hurt, stays back. So I'll work with them individually then. So it's a little bit different for me whether the team's in town or they're not. When they're in town, it really is a big multidisciplinary approach. I mean, we'll sit down with PTs, athletic trainers, chiropractors, massage therapists, strength coaches. Everybody gives their 2 cents as far as what's going on with a given guy and what they need to do in a certain day. And, any complaints that we're hearing from anyone and try to put our brains together to figure out the best way to attack things. So it really is making sure that everybody collaborates on every single guy. I've also spent a lot of time in the clinic, as you said, so it's a little bit of a different world being in a training room versus being in the clinic.
For sure, man. And where's the minor league affiliate for the Nationals?
Well, our AAA is now out in Fresno. This is the first year that it was out there, so we don't have a whole lot of interaction with Fresno. So it's on the other side of the country. But we have a team in Harrisburg, Pennsylvania, in Hagerstown, Maryland, and Potomac, Virginia. So a lot of our guys, if they're local, they'll stick to one of those. If we want to keep them close by, they'll stick to one of those affiliates rather than ship them out to California.
Okay. But yeah, not like a lot of the other teams where you're either in Arizona or Florida, huh?
Well, that's our spring training facility. We're down in Florida.
Okay.
And we share the spring training facility with the Astros. So surprised to run into Jeremiah out on a run somewhere on the complex.
Oh, this will be interesting next season when you guys are all down there together, huh?
West Palm Beach has some bragging rights right now.
Yeah, for sure. We're on the short end of that.
Well, and so Jeremiah, just kind of take me through the way you guys handle things and where your primary base is.
Yeah, so I mean, very similar to what Seth was describing. I mean, what we'll do with a guy a lot will just depend on the injury and what we have going on at the time. Typically, they'll either stay with us here in Houston. If it's a long-term injury, we may send them down to West Palm. But it just depends really on what's going on. One of our biggest things, just philosophy, is we want to keep the players around their teammates as much as we can, obviously doing the right thing for them medically, but keeping them around their teammates. I've seen that firsthand where that just plays a big part in getting guys back and them feeling a part of this team and not feeling, isolated. So that is a big part of what we do with our players. We are fortunate. Actually, we were in Fresno prior to the Nationals going there, and it was hard for us to get really any players to go to rehab assignments out there, and we're a heck of a lot closer than the Nationals are to Fresno, but we're spoiled now. We have our AAA is in Round Rock, which is just outside of Austin, and our AA is in Corpus. So those are both driving distance for our guys. So a little bit easier sell for our guys to go on rehab assignments to those places than when we were working with Fresno, California. So, I mean, that's just kind of a short breakdown. A ton of what we deal with is just recovery for our guys with how much traveling we do, how many games we play, 162 games in 183 days, starting pitchers. It's all about recovery and just dealing with a ton of chronic issues. Of course, you're going to have some serious injuries along the way, but it's really trying to keep our guys going in the middle of the season when no doubt everybody's not feeling great. It's how do we maximize that recovery, really 18 hours between time that they have to end of a game and time they have to be back on the field the next day. So that's what we spend a lot of our time doing is how do we get them in the best place possible for the next day.
Yeah, that's the big difference, really, like compared to the NFL guys when we're talking, it's like, how are we dealing with big boom trauma? Because these guys are just get blown up and then they have a week to try and kind of get better. And then with baseball and basketball too, but baseball even more, it's the buzzword all the time right now is like, what's everyone doing for recovery? And that really seems to be what leads the cart right now. So for people who might not know kind of what baseball injuries entail, what's the kind of nagging issues that you're dealing with lots of times? Overuse stuff, is it all primarily arm related, other related? Kind of thinking through your season last year.
Yeah, it's well, obviously the arm's usually the weak link in the chain, and that's usually where a lot of the symptoms come up, that the shoulder and the elbow especially. And I'd say as far as those nagging day-to-day things like Jeremiah was talking about, it's really a lot of arm discomfort from starting pitchers, from relievers that are throwing every day. You get a good amount of tightness in hips, and you get your obliques and some hamstrings. Those are probably the most common things we had. Although this year, for some reason, we had a lot of guys just get hit by balls, foul balls and broken toes and broken fingers, things like that, which are pretty unavoidable. But for us, I think the recovery is a huge part of it for me, and probably what one of the biggest things that we work on is really movement efficiency. And when I'm trying to explain this to people all the time, we usually say baseball is just it's asking for overuse injuries, right? You're using your body to do something as hard as you can possibly do it 100 times a day, every day. And if there's any inefficiencies, it's going to come up somewhere. And we see it usually comes up in the arm, but you can have inefficiencies in how you load through a foot, or, how much internal rotation you have in a hip. And then you just make compensations and you do that over and over, and it winds up being an arm issue. So I'd say that the biggest nagging things are definitely shoulders, elbows, forearms, things like that. But one of the fun things from a PT side of it is trying to break it down and figure out where's that really coming from. Is it truly just you're using your shoulder too much, or is there something that's causing you to change mechanics that's putting more stress on your arm?
Mm-hmm. Any thoughts on your end, Jeremiah?
Yeah, I mean, really the same thing. I mean, pitchers, shoulders, elbows, we spend a ton of time with those two joints, and position players. I mean, Seth, I'm sure you guys got the same thing, but you just got guys playing every single night, going hard as they can go. So, I mean, really anything lower half, just from a soft tissue standpoint. What can we do to help this player just recover just a little bit better, or, maximize? We really try to maximize our off days. If we have a day game followed by an off day, the next day, and a night game the following day, like that's almost 48 hours without playing a baseball game, which is like vacation for our guys. So using that time as much as we can, and, organizing our treatment before that to maximize that time, because those days are few and far between. So we really got to take advantage of those days for our guys. But it is a challenge, man, with all this travel and just late nights and flights, getting in at 4 a.m. It is a challenge for our guys, no doubt.
Yeah, it's interesting. You talk about those off days, and you would think from a healthcare side of things, people would love them and would always want these off days to catch up on their sleep, and they definitely do like them. But these guys are so focused on their routine and doing something every day that a lot of the guys hate off days. They like the idea of an off day, but they'll come in after an off day and say, I just feel terrible today. I didn't do enough yesterday. And it seems kind of counterintuitive, but a lot of them feel like they need to throw every day. They need to do something every day.
Yeah. No, we see that all the time, especially in the pitchers like you referenced. If they don't throw a baseball for, a day and a half, they feel like they're lost. No doubt about it. They are more sore, just as you described. Yes.
Yeah.
Well, let's touch on baseball recovery then, and what that means, and maybe start into anything you guys might be doing with blood flow restriction from a recovery standpoint. Because I know you guys are both doing it, and if you get like an ACL or something like that, it's probably a no-brainer. They're going to be doing BFR in those early acute stages, but kind of peeling the onion back a little bit. Recovery is just like such a broad term. If you've heard me speak on any conferences, sometimes I bash it because it's such a catch-all. What does it mean? Like, you sleep better, you hurt less, your nutrition's getting dialed in, you're having more protein synthesis, so the muscle recovers quicker. You're doing something to maybe help drive collagen synthesis with the static structures. So what would you do on a recovery day? Back in the old days, is like, we'll come in and let's spin on the bike and do a lactate flush, which is just total BS. There's no lactate left in them. So give me some ideas of what your thoughts are on that, and then start moving into any BFR strategies that you've seen that have helped.
I'll go first. So, I mean, a lot of what we're doing with our guys is whatever you want to call it, active recovery, but just as much as we can, the minute a guy gets off the field, whether it's our starting pitcher or it's a position player, we have certain things we do with the BFR where we literally just do, we call it static BFR, but, some cell swelling and just basically they're just on the table letting the BFR do all the work, which is almost counterintuitive to some stuff that I believe as far as making athletes move and make them do stuff. But when you put it in perspective of this guy just played in 15 straight games, him doing a lot of movement is probably not going to help him. But it's basically just how do we downregulate their system after they've been, flying around the field for 3 hours and how do we get them recovered from a lower body standpoint or their arm? How do we get them ready to sleep? Because that's another thing that we really deal with is I know starting pitchers, they may not get to bed till 3 or 4 in the morning the night after they pitched. Everybody thinks, well, they're so tired. Well, yeah, they're tired, but they're so amped up and they're reliving every single pitch. So it's how do we get them in a mental state where they can actually sleep? So that's another real challenge that we face on just simply getting guys to sleep. And, that doesn't even get into the travel or if you got, a newborn, all that stuff that goes into real life stuff. But we've just really taken it the minute you guys, we get them off the field, we try to get, BFR strapped on them. And yes, we will use the bike from time to time. But a lot of times it just may simply be chilling on the treatment table while, myself or one of our guys, chat with them. It's pretty simple, but if you do it consistently, we found it works pretty good.
Hey, Jeremiah, I'm kind of curious, and you too, Seth, do you bring in any outside help to kind of help you with prepping these folks to sleep, to help with their sleep quality, that kind of thing? Are there specific strategies that you use on that front?
Yeah, we had, we talk about sleep a good amount. We actually had a physician come into spring training and gave us the whole rundown on sleep. And we hear this a lot in the PT world, but all the information that's come out the last few years on sleep hygiene and, just unwinding your system and how to start shutting things down. So we talk a ton about that. We have a sleep room at the stadium. So obviously try to encourage people to use that when they get in after a 4:00 travel. So yeah, we talk about sleep a good amount and are always trying to promote that. And that's obviously when your body heals. So the more we can get them on a good cycle, the better that is. But like Jeremiah said, with travel, that's almost impossible.
Yeah, we do a very similar thing. We have several people come in during spring training, try to take advantage of that time with guys to try to promote just good sleep habits, to try to take with them, in spring training throughout the season. And we're constantly, honestly, just nagging the guys about little things to help them sleep better, whether it's what they eat right before bed or it's getting off your cell phone, not watching TV, 20 minutes before bed. It's temperature control. It's certain sheets. It's controlling the light that comes underneath the door of your, bedroom. All these little things that we're just constantly on these guys about to try to, I wouldn't even say educate, just remind them that these little things can make a difference for you. So it is a big thing right now, and we try to take advantage of it and educate our guys as much as we can.
Yeah. I'd say we also another aspect in addition to all the sleep hygiene that drives me a little bit crazy is sleep positioning. It's something that we talk about all the time with regular patients and definitely with players. But the idea of just having a pitcher come in and say, my neck's hurting because of how I slept last night, or didn't have a good pillow, that's a pet peeve of mine. It drives me a little bit crazy that these guys should know how to sleep, and we should be covering sleep position quite a bit with them, but we still hear it all the time.
So what do you use the perfect pillow thing that one guy is, I need to get one of these. What do I need, man?
A lot of good options out there.
Yeah.
Like he's trying to be secretive because he's thinking like this was the key to that World Series championship.
That's
I see what's going on right here, Seth.
Yeah, they all looked rested.
He's trying to get a good sponsorship.
Yeah. Well, okay. So, Yeah, and sleep hygiene is huge. I know in the DOD that was massive for us. Just getting the freaking guys to, one, not drink booze late at night, or not be on their phones or gaming. I mean, all these service members freaking love to play video games, and they were like pitchers, wired until 4 a.m. because they've been playing these war games the whole time. So, yeah, that's huge. And we've always said no one's going to recover if you don't get into a deep sleep. That's a known fact, but it's obviously hard to make happen, especially when you're traveling from coast to coast. Touching back, Jeremiah, so the ischemic preconditioning sounds like what you're doing, or cell swelling, where you're just putting it on passively on the guys. And we're getting more and more anecdotal reports. We did a podcast a little while back discussing the most recent literature and how it looks like it might be aiding recovery as well as maybe aiding performance. It looks like it's real, and you and I talked about it. It looks like, with that stuff and with all things with high performers, there's obviously some people that respond extremely well to things like that, and those are the ones you just got to keep doing it with. And some people might respond a little, and some people might feel like it takes them the other direction. Is that what you guys see with BFR and with recovery, or with anything else, that you kind of have these like really good responders and maybe not so much on the other side?
Yeah, 100%. I mean, we have a good amount of our roster that will purposely seek this out post game, that we don't even have to really push it with anymore, which obviously that's awesome. It makes our job a little bit easier. But I know guys that they don't even really ask. They don't care about the science at all behind it. They just do it, and they've done it 2 or 3 times, and then it makes them feel better. Yeah. They get up off the treatment table just feeling refreshed, which if we can do that and send them out the door feeling, 5% better headed into, tomorrow's game, then that's a win for us, 100%. Yeah. I mean, we'll do that. We will do just, depending on, what are they dealing with as far as soreness, or they've had a little injury here or there. We'll add some stuff post game, whether it's simple, like it might just be active range of motion stuff, but just little stuff that if we get our guys to be consistent with it, I know we'll pay dividends. That's what we really tried not to overwhelm our guys with a bunch of stuff. Just be consistent with little stuff.
Perfect. Yeah, and so that's what's interesting with this. And you can look at it from a recovery. It's this whole kind of range. So just laying there on the table and having your limb go into ischemia, there's potential that we're blunting muscle damage from some studies that are out there. And so if you say recovery, well, one recovery thing we want to look at is how quickly can I make the muscle recover? Because that's important for an athlete. So if you look at the net protein balance equation, you're either synthesizing protein or you're breaking it down. And so if these guys are laying there, they're getting it on their limb, that's shown to have a protective effect for muscle, for the heart, for the brain, for all sorts of organs. We don't understand why, but it does. Even on blood draws showing creatine kinase levels are lower. And so that's helped them recover. But then if they do a little bit of exercise, maybe stem, ride the bike, then maybe they're blunting the muscle damage, but also synthesizing some protein as well. And then you're starting to maybe get this extra boost of recovery. So, it seems like, you kind of started, if they're just smoked and that's all they can do, hell yeah, just get them on the table and see if this makes them feel better. And if it does, then there is some science behind it, and that might be a responder. If they can do a little bit of exercise, I think you'll get a little bit more from it. And then you just got to kind of gauge where your guys are. But I think it's a perfect way to go about it. And what we're hearing and seeing from more and more teams all the time is these guys post game. Are you doing it on leg only, on arm for recovery now, or?
We're doing it on arms. We're doing it on legs. I would say in general, probably more, movement-based stuff from a pitcher standpoint when we have it on their arms. So actually doing some, what would be considered, shoulder therapeutic exercise. Not always. Sometimes, we're trying to follow the same principles. If a guy has pitched a lot in the last, week, 10 days, whatever, we try to be smart and not do a ton with them. But we're definitely using it on arms and legs, just the same. But try to follow the same concepts regardless, whether it's position player or pitcher.
And I know Brad Lambert, who's part with the Methodist system, who's a healthcare system for you guys. I talked to him today, actually. and he does have the trial going right now in the MLB. The first cohort finished up, but doing BFR on pitchers twice a week after they've thrown. So far, looks like promising data, but we're probably gonna have to get a whole nother cohort enrolled to have it powered high enough to get there. But that's gonna be interesting to see where that goes, because there's a lot that's being tracked, not only increasing strength in the shoulder, but increasing muscle size, and also tracking things like pitching velocities and things like that. There's probably way too many variables we're looking at pitching velocities and all of that, but a lot of interesting data that we're going to see. And also from a safety and efficacy standpoint, you want to make sure both those things are going there. And so far, I don't think there's been any issues from a safety profile. And we can open that can of worms here in a little bit too. Seth, you got anything on your end? I know you're seeing the more, not on the recovery standpoint as much probably, but more on the injury side back at clinic. But
yeah, I mean, and also with the team on, when I'm there, I think it is used more, definitely more on the injury side. That's for sure. I think one of the challenges is when you get buy-in from these guys, and how early you introduce it to them, because like we know a lot of these guys, they have their own things they like to do for recovery. One guy, it might be, he likes to go do contrast, and one's using Normatex or Mark Pros and things like that. And to get buy-in from everybody sometimes is not always the easiest when they've had their routine that they like to do. But I do see, definitely the need for that. And at least when guys are having little minor tweaks in muscles and things like that, to try to tell them, we're always trying to get them to work out pretty much on a daily basis, to be able to do some stuff under BFR. So it's a lot lower load, so they're not stressing it quite as much, and hopefully promoting a little bit more tissue repair. So we use it more in that sense than just in a true recovery post game.
How about from an analgesic standpoint? Anything you guys have seen or have tried where someone has a nagging injury and they seem to get this like pain relieving response from BFR? And I know some of the NBA teams, especially towards the end of the season, that was getting pretty popular. Anything you guys have tried with that?
I haven't. I mean, I like the idea of it, but we haven't used it in that aspect yet.
Yeah, I mean, I would say the same thing. We haven't done really much with that. It's probably some of it's just some of the scenarios that I can think of right now that we could potentially use it in. I don't know if the athletes would be on board with it, to be honest, even though the research might be really good for it. But I've not used it a ton in that environment, no.
Yeah, it's a very it's a sport with athletes that a lot of tradition and lore in their routines. And so you definitely don't want to mess around with any pregame routine. I definitely would understand. So Jeremiah, you just presented on blood flow restriction at the winter meetings. Can you kind of give us a little synopsis on kind of how it all went, what the response was? Like you said, maybe about 50% of the MLB is probably doing it right now, although we don't have hard and fast numbers.
Yeah. So just a great opportunity to go and present there. The MLB actually added an extra section Sunday morning, which is basically just strength coaches, PTs, athletic trainers, that group meeting together, because obviously we're the group that is really working with the athletes every single day and just interacting with them almost 24/7. So got the opportunity to go and present with Brendan Verner, our strength coach here with the Astros, on really what's the science behind it? How do we use it in the, traditional setting, whether it be rehab or the training room? How do we take that into the weight room as well, and not just use it only in the training room? Because that's one of our philosophies is we want guys really – training room and weight room are really one room, if that makes sense, to where we try to get, even if a guy can't do much, get him in the weight room and be around the healthy players as much as we can. But specifically, as far as what I presented on and how that went, it went really well overall. Just really the main purpose of the whole thing was just to get discussion amongst teams on, hey, how are you using this? How are you not using it? And overall, just very well. I mean, good conversations about, hey, we've used it in the recovery setting, or post ACL surgery to reduce atrophy when you can't do a ton of strengthening of the quads yet early on in the rehab process, or how early can you use it post Tommy John? How quickly can you implement it? What do you need to be careful of? And some of this, a lot of just the safety concerns, because to some people, they've just not seen it or used it. So, hey, there's this new thing on the market that people are getting really good results. What do we need to be concerned about as a clinician, just to make safety our number one priority for our players? So just walking through some of that with a lot of the teams, and just, good questions from the group and everything. There's definitely probably 50% of teams are doing it on some level. Some teams are doing it across the board at every single level. There's maybe some teams that maybe just have one or two units. But overall went good. So just all in all, a great opportunity to go and present to that group, with our head strength coach, and, just kind of get a little bit more info out there, because in the end, everybody, we obviously compete against each other on the field, but we just want to keep guys healthy and give them the opportunity to compete no matter what team they're on. So just a great opportunity.
It's awesome your strength coaches are on board. That's not always the case, not only with blood flow restriction, but sometimes there's a literal wall between the training room and the strength room. And so having your coach even jumping in on that talk, strength coaches don't like to talk low load.
Yeah, no, it's definitely a little bit of a challenge, but no, he's awesome, because he, just in baseball, you got to be able to change and do things a little bit different every once in a while. So we take, that's a big thing for us, is having our whole staff on the same page, and not really having any silos or egos about how we do business around here. We take great pride in that. So it's good.
It's rough, man, having to do winter meetings in San Diego. I don't think you can call that freaking winter meetings.
Yeah, I was trying to stay for another week, but my wife wasn't on board with that, with our two little ones at home, so I had to come back.
Dude, you're living my life then. That's I'm Mr. 6 o'clock flight in the morning guy. Well, and so let me discuss this then, and this whole safety, so, man, I think we've gone safety ad nauseum on this podcast. If you go to our course, we go deep into it. We went through every kind of safety profile we could in the DOD when we were first starting to do this on the Wounded Warriors. So Mike Reinhold is a buddy of mine, a baseball guy. He's with the White Sox now, I think, consulting with them. He put out a tweet the other day. I'm not doing blood flow restriction on my pitcher's arms anymore because I'm worried about neurovascular compression. And so I want to thank Mike for making my freaking cell phone blow up that morning, with everyone going, what the hell, what's going on with this neurovascular compression? But, what he didn't really do is give any rationale that I can see. He mentioned, baseball players' arms seem to be kind of, overridden with this sympathetic drive or neural compromise from what they do. And that BFR is going to exacerbate that, but no real actual evidence behind that. And so I can get your guys' thoughts on it. I'll put out what we know of what blood flow restriction does to a nerve and nerve conduction velocity. So there's a ton of tourniquet literature that's looked at the potential damage to nerves, and it's pretty straightforward. It dialed into when you go have surgery on a limb. They follow these AORN guidelines, which part of that is set up so that the tourniquet uses the lowest pressure possible. They use wide tapered cuffs. They're pneumatic, and they control the pressure plugged into the unit to mitigate nerve damage, because nerve damage is something that can happen with tourniquets. We just had a giant retrospective study come out of the DOD from the wars, and from the battlefield tourniquets, the biggest injury from the tourniquet was actual nerve damage from a pressure gradient. But if you look at when you're using a pneumatic tourniquet, and it's on a limb, and what it does for nerve compression velocities. The first study was done by Brian Clark almost a decade ago, I think. And so basically they looked at the H reflex, so more of a sensory response after you do blood flow restriction for 4 weeks. And there was no change at all in nerve conduction velocity or that H reflex profile from chronic blood flow restriction done. And a new study just came out kind of timely about 2 days ago that went into a deeper dive of this. And so they looked at M wave, so motor and H wave, and the latencies between those. And so that's a more sophisticated kind of deeper way to look at it. And if that changed nerve conduction velocities at all. And they also looked at it at the kind of the pressures that we're using now in research and clinically at 60% limb occlusion pressure and 80% limb occlusion pressure. And then they looked at those pressures with exercise to see, does exercise add something else to it? And after looking at that, no change at all in M, H wave, or nerve conduction velocity at 60, 80, or 60 or 80 with exercise. So if you look at it from, studies that have looked at it kind of from a science-based perspective, it doesn't look like there's any compromise when you're controlling for this in the right way. And, I'm not sure exactly what Mike's using. Maybe he's got a more narrow tourniquet that might be causing issues on his guys or something like that. But we haven't had reports from the teams. I know, Jeremiah, you and I have talked. We haven't really heard anything from your end either. That study, their conclusion was basically if you stay within this, subarterial occlusion range and you use wide cuffs, you keep your tourniquet times to a minimum. There should be no issues at all with any neurovascular or nerve conduction velocity loss. So that's what I have from a kind of a science perspective on it. Any thoughts on y'all's end? I think y'all agree since you're kind of already doing it and haven't seen issues.
Yeah. I think you bring up a couple good points, Johnny. First of all, the type of tourniquet that's used, and I'm not just saying this because I'm talking to you, but obviously I like the units that we use quite a bit. And like Jeremiah was saying, bringing it to the winter meetings and talking to a lot of teams, I also get to interact with some other teams, with football, with hockey, and we see that it's used pretty prevalently, but it's all across the board as far as which systems they use. And like you're saying, a lot of them are using just the real narrow cuffs or some of these tubes that you just pump up. So I think it's tough to say that, just make a blanket statement that BFR would cause compression if not everybody's using the same devices. From my perspective on pitchers, I have absolutely no issue using it on pitchers. And, we definitely get pitchers that have neurovascular symptoms at times, but at least the ones that I've seen, the vast majority of that comes from more proximal issues. It comes from scalene hypertrophy and first rib issues and all brachial plexus issues a little bit higher up. So I don't think that has anything to do with what you're occluding down on the proximal arm. So I think saying that pitchers get neurovascular symptoms, so I'm not going to do limb occlusion, for me doesn't really make sense because it might be coming from something completely different.
Right. And when the science says putting the tourniquet on isn't doing anything to the neurovascular bundle,
right.
From what we're seeing, at least from a nerve conduction velocity, H wave, M wave, if it's kind of smacks whenever we were first starting to do this and our surgeons said, you can't put that on people, it's going to cause clots. It's like, wait. Well, let's look at what the science says here. And we've got studies and mechanistically, we don't see that. So it kind of feels like that. We're saying, well, just trust me, I know it does sort of situation here. I don't see any concerns. Haven't heard of any concerns, but it'll be a fun debate to see kind of where people go on it.
Yeah. I think that's similar to saying, well, because they get this, I'm not going to push on the scalenes or do soft tissue up there because it has a temporary effect of possibly causing some ischemic responses and some neurovascular compression. So, that just doesn't make sense to me. Yeah.
And heavy load training has shown that it does change nerve conduction velocities and does have an effect on that as well. So, then it's like, well, are you not going to let these guys lift a heavy weight?
Right.
Are you not going to check their blood pressure because you're nervous that, that thing's going to compress? So kind of a weird blanket statement that was thrown out there. Cool. Any other thoughts or cool pearls you have? What's it going to take for us to beat the Nationals next year, man? A lot of movement going on right now in the postseason. Players all over the place. You guys getting contracts like these players are getting?
Got to see who comes back.
Yeah.
Yeah, everybody's busy right now. Maybe if we get more BFR units than the Nationals, maybe that'll
Yeah, well, if that shows it, what makes you win a World Series is blood flow restriction, hell yeah, I'm in a good world.
You'll be a rich man, Johnny.
Well, cool, fellas. If you guys don't have any other parting shots here, then I think I learned a lot from you.
Yeah, I would say I had one thing. I think a lot of what we do, just hands-on, at least from my perspective, is a lot of like neuromuscular facilitation and a lot of PNF work and getting, the right muscles firing and the right activation work. And I think BFR just goes so nicely with that. And I was just talking to one of my therapists about this today that, let's get the right things firing and then using BFR to just get everything kicking in that much better. I've just seen great results with in the clinic. So I think sometimes I hear from a therapist perspective, well, they kind of shy away from it. It's a modality and I want to just have my hands on the patient the whole time, which I'm a big believer in. But I think seeing how it actually couples with what we're doing manually is pretty awesome too.
Yeah. It's just another tool in that toolbox, right?
You got it.
Yeah. Well, cool. And also I'll say, you guys, your institutions are putting the money where the mouth is. Inova has clinical trials right now. We're looking at BFR with ACLs. Right. The Astros are doing some studies with the MLB, and Methodist healthcare system up there has more dang BFR studies than I can shake a stick at right now. So y'all's institutions are also help lead the way to make us understand the science a little bit more. So that's badass. Now get enrolled in patients and get these studies done, please.
Yeah, every time I talk with the guys over there at Methodist, whether it's Matt Holland or Corbin, they got something new study that we got going. So they got a lot of stuff going. Yeah,
freaking Lambert, my page is full of studies that he's planning right now. So you're gonna freaking be leading the world. And let me tell you, I don't know if you can trust Matt Holland with any of his blood flow restriction stuff, because he's an old friend of mine, and I started telling him I was going to start doing maybe a blood flow restriction course years ago. And he came to town. He said, "Hey, can I take that course?" And I told him it's not ready yet, but I'm close. And so he said, "I'll just come do it." And he was my first blood flow restriction certified person ever.
Oh, really?
Me and him in one person course. And it was the worst damn course. Try and teach someone with one guy just sitting there in front of you.
I'm gonna get on him tomorrow, because I'm gonna see him. I'm gonna tell him he probably has no idea what he's even talking about with blood flow restriction.
I didn't know what I was talking about. I didn't know what half those slides meant back then. So
he's the one that taught me a bunch of stuff. So I don't know if I can trust the dude.
Yeah, he's making it up, man. Well, no, he is BFR certified #1.
Oh, interesting.
All right, guys. Well, appreciate your time, and stay in touch. We'll talk soon.
All right. Sounds good. Thanks, Johnny.
Thanks, guys.
Thank you, guys.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.